So let us talk about liver cancer. The topics covered include the anatomy and physiology, the definition, the etiology and the risk factors, the pathophysiology or the pathogenesis, the complications, the symptoms, the diagnostics and laboratory procedures, the management, which includes the medical or the pharmacologic, surgical, and the treatment modalities, nursing diagnosis and nursing management, and the prognosis. So, I have listed here some of the common liver diseases. Uh, Here we have the chronic hepatitis, the liver cirrhosis, the fatty liver, the alcoholic hepatitis, and our topic for today, which is the liver cancer. Let us talk about the liver. So, the functions of the liver first is digestion. So, bile neutralizes stomach acid and emulsifies fats, which facilitates fat digestion. Bile is a fluid that is made and released by the liver and stored in the gallbladder. It breaks down fats into fatty acids, which can be taken into the body by the digestive tract. Second is excretion. The bile contains excretory products such as cholesterol, fats, and bile pigments. Example, the bilirubin that results from hemoglobin breakdown. The third is the nutrient storage. The liver cells remove sugar from the blood and store it in the form of glycogen. They also store fat, vitamins A, B12, D, E, and K, and copper and iron. Next is the nutrient conversion. The liver cells also convert some nutrients like amino acids, which can be converted to lipids or glucose or fats. And fats can be converted to phospholipids, and vitamin D is converted to its active form. The next function is the detoxification of harmful chemicals. The liver cells remove ammonia from the blood and convert it to urea, which is eliminated in the urine. Other substances are detoxified and secreted in the bile or excreted in the urine. And last is the synthesis of new molecules. The liver synthesizes blood proteins such as albumin, fibrinogen, globulins, and clotting factors. So let us talk about the anatomy of the liver. So, the liver is the largest internal organ in the human body. It is reddish to brown in color and feels rubbery to touch. So normally you can feel the liver because it's protected by the rib cage. The liver has two large sections called the right and the left lobes. So we have here the anatomy. The upper picture is the anterior view of the liver. Here we have the blood vessels, the inferior vena cava, and the two lobes, the right and the left lobes. It separates by the falciform ligament, round ligament, and under we have the gallbladder. And the lower picture is the inferior view. In here, it is the histology anatomy of the liver. So now let us talk about liver cancer. So what is liver cancer? Primary liver cancer is the sixth most commonly diagnosed cancer and fourth leading cause of cancer mortality worldwide in 2018, and it is more common in men than in women. Because the production of a protein promotes inflammation appears to be linked to the higher incidence of liver cancer in men than in women. The researchers at the University of California, San Diego, or UCSD School of Medicine said, and outcomes are poor with an estimated 5-year net survival of 19%. The types of liver cancer include hepatocellular carcinoma, or the primary liver cancer, cholangiocarcinoma, or the bile duct cancer, angiosarcoma or hemangiocarcinoma, or which it begins in the blood vessels of the liver and grow quickly, and the secondary liver cancer, also known as the liver metastasis, which occurs when primary liver cancer spreads to other body parts. And most liver metastases originate from colon, or colorectal cancer. According to a study about the global trends in incidence rates of primary adult liver cancers, there are two major histological types of liver cancer. First is the hepatocellular carcinoma, which contributes 75% of all liver cancer cases, and next is the intrahepatic cholangiocarcinoma, which contributes 12 to 15% of all liver cancer cases. So, first, let us focus on the hepatocellular carcinoma, or the HCC. Its subtype include the fibrolamellar HCC. This type of cancer begins in the liver cells, meaning it originates in the liver cells. It occurs in the presence of liver disease or cirrhosis, and also viral hepatitis, which is more common in hepatitis B and C. So the etiology and the risk factors, first is the liver diseases such as cirrhosis, viral hepatitis, and hemochromatosis. Hemochromatosis is a hereditary disorder that causes the body to absorb too much iron. Next is the dietary aflatoxin exposure, such as the aflatoxin in peanuts, rice, wheats, and etc. Another risk factor is smoking and high alcohol consumption with non-alcoholic fatty liver disease associated with obesity and diabetes. So the pathogenesis is presented in here. The risk factors and the etiology, the aflatoxin B1, which can lead to P53 mutations, which lead to P53 inactivation, which could result to proliferation and loss of growth control, leading to genetic alterations. Next is the hepatitis B virus or the hepatitis C virus and other host factors, which these include inflammation or cirrhosis, which can lead to necrosis, regeneration, and genetic alterations. Also, the alcohol consumption can lead to inflammation, which may cause necrosis or regeneration. And these all could lead to genetic alterations leading to hepatocellular carcinoma. So the complications include hepatic failure, metastasis, which is the most common in the lungs, followed by the lymph nodes and the bones and other areas in the body, which include the adrenal glands, the peritoneum, the diaphragm, soft tissues, brain, skin, and oral cavity. And death occurs from cachexia, variceal bleeding, or tumor rupture. The symptoms include abdominal pain, weight loss or loss of appetite, jaundice, fever, tiredness, and itchy skin. Next, we have here the diagnostic tests and laboratory procedures. First is the complete blood count, or the CBC. Low hemoglobin levels may be related to bleeding from varices or other sources, and thrombocytopenia is a platelet count below 100,000 microliter, which is highly suggestive of significant portal hypertension or splenomegaly. We have here the electrolyte levels. Hyponatremia is commonly found in patients with cirrhosis and ascites and may be a marker of advanced liver disease. We have here the liver function tests, the coagulation studies, the AFP determination. Also, this includes the ultrasonography, the magnetic resonance imaging or the MRI, and the tissue biopsy. According to the Barcelona Clinic liver cancer staging system, there is uh, staging that occurs in diagnosing liver cancer. Here we have the stage 0, the stage A to C, and up to the stage D. This is according to the nodules according to its size. So here in stage 0, uh, the very early stage, the nodule is less than 2 centimeters, and uh, it could the treatment could include resection. Uh, the stage A to C first is the early stage, or the letter A. The nodules is less than 3 centimeters, and here, if there are associated diseases, uh, it could possibly include the RFA, the ablative therapy, or if there are no associated diseases, it could lead to liver transplantation. Another is intermediate stage, or letter B. Uh, the treatment could include transarterial chemoembolization. And the letter C, or the advanced stage, uh, it could lead to chemotherapy medication such as sorafenib, which is another palliative treatment. And the last stage is the stage D, which is also called as the end stage. Uh, the treatment is to treat symptoms, which is also a palliative treatment. The management. So patients should be cooperatively managed by hepatologists, transplant and hepatobiliary surgeons, medical oncologists, interventional radiologists, and palliative care specialists. The treatment options for hepatocellular carcinoma depend on the following. First is the size, number, and location of tumors. Next is the presence or absence of cirrhosis, the operative risk based on extent of cirrhosis and comorbid diseases, the overall performance status, the portal vein patency, and the presence or absence of metastatic disease. And only about 5% of hepatocellular carcinoma patients are suitable for transplantation. These patients may have a 5-year survival of greater than 75% with tumor recurrence rates as low as 15% at 5 years. So first is the non-operative therapy. We have here the transcatheter arterial chemoembolization. TACE is performed by an interventional radiologist who selectively cannulates the feeding artery to the tumor and delivers high local doses of chemotherapeutic agents including doxorubicin, cisplatin, or mitomycin C. To prevent systemic toxicity, the feeding artery is occluded with a gel foam or coils to prevent flow. The most common complication of this therapy is post-embolization syndrome. Next is brachytherapy. This uses 20 to 40 micrometer glass beads that are loaded with radioactive yttrium and delivered angiographically. The radiotherapy is then delivered over 10 to 12 days with a total dose of about 150 GY. Next non-operative therapy is chemotherapy. The US FDA approved some drugs such as sorafenib, regorafenib, nivolumab, and lenvatinib. Another is the surgical therapy. First, we have the surgical resection. Liver resection is the operation of choice for patients with tumors smaller than 5 cm in the absence of cirrhosis. After liver resection, as many as 75% of patients will develop intrahepatic recurrence within 5 years. Pathologic characteristics associated with a higher rate of recurrence include the following. First is the tumor at the resection margin. Next is the presence of cirrhosis, vascular invasion, advanced tumor grade, number of tumor nodules, and microvascular portal vein thrombosis. Next is the liver transplantation. Complete hepatectomy eliminates the possibility of local recurrence at the resection margin and, moreover, removes the cirrhotic liver, which is clearly predisposed of tumor formation. It also eliminates concerns about the capacity of the post-resection liver remnant to provide adequate liver volume. Another is the ablative therapy. It can be performed percutaneously, laparoscopically, or via an open surgical approach. We have here first is the percutaneous ethanol injection. PEI involves the injection of alcohol directly into the tumor, leading to complete ablation of up to 70% of the lesions, which are less than or equal to 3 centimeters. It is generally performed under the guidance of ultrasonography and requires 4 to 6 sessions to complete the ablation. Next is the RFA. So, the radiofrequency ablation is a minimally invasive treatment, one of several types of ablation therapy where surgery is not a good option. Guided by imaging, a thin needle or probe is inserted through the skin and into the tumor. This procedure can be done under the guidance of an ultrasonograph, computed tomography, scan, or laparoscopy depending upon the patient's health, the location of the tumor, and the expertise available in the center. Next is the cryotherapy. Cryotherapy is the use of extreme cold to freeze and remove abnormal tissue. For the long-term monitoring, despite optimal treatment, hepatocellular carcinoma continues to have a high recurrence rate. It recurs in 50 to 80% of patients following resection, with the majority of recurrences developing within 2 years. CT scan should be performed at 1 month post-resection to ensure complete tumor clearance. After this initial scan, serum AFP measurements and repeat imaging studies should be obtained every 3 to 6 months depending on the likelihood of recurrence. After 2 to 3 years, it appears safe to increase the follow-up interval. The prognosis. Hepatocellular carcinoma has become a major contributing factor to morbidity and mortality rates. Undergoing transplantation leads to excellent results. The addition of chemotherapy, changes in immunosuppression regimens, increasing the use of living donors, and salvage transplantation post-resection, survival rates may improve. The second major histological type is the cholangiocarcinoma, and the subtypes include intrahepatic cholangiocarcinoma or the ICC, the hilar cholangiocarcinoma, and the distal cholangiocarcinoma. It is a cancer that occurs in the slender tubes or the bile ducts that carry the digestive fluid bile. The bile ducts connects your liver to your gallbladder and to your small intestine. And cholangiocarcinoma is also known as the bile duct cancer, which is very difficult to treat. This type of cancer is difficult to diagnose, extremely aggressive, and has a very poor prognosis because the symptoms are late and is relatively resistant to the therapies currently available. So, listed are the etiology and risk factors. We have here the cholestatic liver diseases, such as the primary sclerosing cholangitis, the fibropolycystic liver diseases, and etc. Next is the liver cirrhosis, the biliary stone diseases, such as hepatolithiasis, infections such as liver flukes. Another is the hepatitis B and C, and the human immunodeficiency virus, or the HIV. Another is the inflammatory diseases such as inflammatory bowel disease and chronic pancreatitis. Another is toxins such as alcohol and tobacco abuse. Next is the metabolic conditions such as diabetes and obesity. And other is the genetic disorders. According to a study by Leva Eliades et al., we have here the effects of stromal support cells on tumor growth and metastasis. B cell, the epithelial mesenchymal transition or the EMT, the M, the monocyte, the T cell, and the TAM or the tumor-associated macrophage. So, the lymphangiogenesis, the extracellular matrix, the cancer-associated fibroblasts, the vascular endothelial cells, and the immune or the inflammatory cells contribute to the growth, supply, and metastasis and invasion of the cancer cells. Um, According to the New Insights Asian Pacific Journal of Cancer Prevention, we have here the pathogenesis of the cholangiocarcinoma. Here is we have the biliary epithelium, and if inflammation occurs, contributing from the risk factors, which is the uh, liver liver flukes, hepatolithiasis, and etc. It could lead to epithelial injury, and then it could result to reactive epithelial hyperproliferation, genetic and epigenetic alterations, which can lead to cholangiocarcinoma, and if this disease progresses, it could lead to metastasis. Symptoms include weakness, pain, nausea and vomiting, jaundice, or sepsis. The complications of cholangiocarcinoma include the infection of the biliary tree and the cirrhosis, which contributes 10 to 20% of the cases. The laboratory and diagnostic procedures. First is the routine laboratory studies, which include the bilirubin levels, the glutamyl transferase or the GGT, and the levels of aminotransferases, the, the alanine aminotransferase. Now there is the tumor markers. First is the carbohydrate antigen 19-9 or the CA19-9 can be evaluated in pancreatic and bile duct malignancies as well as in benign cholestasis. Another is ultrasound. It may present biliary duct dilatation and larger hilar lesions. Another is the CT scan. It may present ductal dilatation and large mass lesions. Another is magnetic resonance imaging or MRI, which could demonstrate hepatic parenchyma. Another is endoscopic retrograde cholangiopancreatography or the ERCP. It presents the site of obstruction by the retrograde dye injection and excludes ampullary pathology by endoscopic evaluation. And then the next is angiography. This is done if surgical treatment is being considered. The histologic findings. Classic cholangiocarcinomas are well to moderately differentiated adenocarcinomas that exhibit glandular or acinar structures. Intracytoplasmic mucin is almost always observed. Characteristically, cells are cuboidal or low columnar and resemble biliary epithelium. In more poorly differentiated tumors, solid cords of cells without lumina may be present. The staging for cholangiocarcinoma first is the TNM. The TNM staging first is the tumor. The TX, the tumor cannot be assessed. In T0, there is no evidence. In carcinoma in situ, high-grade dysplasia. And in the T1, the tumor is confined to the bile duct with extension up to the muscle layer of fibrous tissue. And if it's T2, the tumor invades beyond the wall of the bile duct to surrounding adipose tissue or tumor invades adjacent hepatic parenchyma. In T2A, tumor invades beyond the wall of the bile duct to surrounding adipose tissue. And the T2b, tumor invades adjacent hepatic parenchyma. And in the T3, tumor invades unilateral branches of portal vein or hepatic artery. And then the T4 is the tumor invades main portal vein or its branches bilaterally or the common hepatic artery, or unilateral second-order biliary radicals bilaterally with contralateral portal vein or hepatic artery involvement. For the M is the regional lymph nodes. For the NX, regional lymph nodes cannot be assessed. And for the N0, no regional lymph node metastasis. And for the N1, 1 to 3 positive lymph nodes typically involving the hilar, cystic duct, common bile duct, hepatic artery, or the posterior pancreatoduodenal and portal vein lymph nodes. And for the N2, 4 or more positive lymph nodes from the sites described for N1. And for the last, for the M, is the metastasis. For the MO, there is no distant metastasis. For the M1, there is the presence of distant metastasis. The management. First is the stent placement. Stents can be placed via endoscopic retrograde cholangiopancreatography or the ERCP or percutaneous transhepatic cholangiography or the PTC to relieve biliary obstruction. Stenting may relieve pruritus and improve quality of life. Next is the photodynamic therapy. It is an effective in restoring biliary drainage and improving quality of life in patients with non-resectable disseminated cholangiocarcinomas. Another is radiation therapy. Adjuvant and preoperative radiation therapy has been used to reduce tumors in an effort to make them resectable. Next is the chemotherapy. Gemcitabine and cisplatin are the first-line pharmacotherapy in inoperable biliary tract carcinoma. Next is the 5-fluorouracil, which has a partial response rate of about 12%. For the target therapy, the U.S. FDA in April 2020 approved pemigatinib for previously treated unresectable, locally advanced or metastatic cholangiocarcinoma with a fibroblast growth factor receptor 2 fusion or other rearrangement as detected by an FDA-approved test. It is a small molecule kinase inhibitor that targets FGFR1, 2, and 3 by inhibiting FGFR1 to 3 phosphorylation and signaling. FGFR inhibition disrupts tumor cell proliferation, survival, migration, and angiogenesis. The further surgery is the complete surgical resection. Another is the orthotopic liver transplantation. It is considered for some patients with proximal tumors who are not candidates for resection because of the extent of tumor spread in the liver. The prognosis. The 5-year survival rate for intrahepatic bile duct cancer is 8%. If the cancer is diagnosed at an early stage, the 5-year survival rate is 24%. If the cancer has spread to the regional lymph nodes, the 5-year survival rate is 7%. And if it has spread to the distant parts of the body, it could lead to 2%. And this is the general diet and prevention for liver cancer. For the diet is to avoid alcohol and hepatic toxins as mentioned earlier in the slides. For the prevention is this vaccination and screening for hepatitis B and C virus. Also is to avoid alcohol intake, implementation of safe injection and transfusion practices, HCV testing, and avoid obesity and type 2 diabetes. And also promote healthy lifestyle and engage in physical activities. Let's go to the nursing diagnosis and nursing management. First, we have the acute pain related to side effects of cancer therapy agents as evidenced by reports of pain. The management first is to determine pain history and relief measures used, determine timing of breakthrough pain when using around-the-clock agents, whether oral, IV, or others. Provide information about what to expect of painful effects of particular therapies, such as surgery or chemotherapy. Provide non-pharmacologic comfort measures such as repositioning, massage, back rub, diversional activities such as music and television, and encourage the use of stress management skills such as relaxation techniques, music, or therapeutic touch. And for the collaborative is to administer medications as indicated, uh, which include the opioids, acetaminophen, and others. The second nursing diagnosis is fear related to separation from family due to hospitalization as evidenced by expressed concerns regarding changes in life events. Nursing management includes encouraging the patient to share thoughts and feelings, provide open environment in which patients feel safe to discuss feelings or refrain from talking, maintain frequent contact with patients, talk with and touch patient as appropriate. Be aware of the effects of isolation on patient required by immunosuppression. Next is to provide accurate, consistent information regarding diagnosis and prognosis. Permit expressions of anger, fear, despair without confrontation. Give information that feelings are normal and are to be appropriately expressed. Explain recommended treatment, its purpose, and potential side effects. And you have to promote calm and quiet environment and encourage and foster patient interaction with support systems. The third is imbalanced nutrition, less than body requirements, may be related to consequences of chemotherapy as evidenced by decreased subcutaneous fat. Nursing management first is to monitor daily food intake, have patient keep food diary as indicated, weigh daily as indicated, and encourage patient to eat high-calorie, nutrient-rich diet with adequate fluid intake, and encourage the use of supplements and the frequent or small meals spaced throughout the day. Create pleasant dining atmosphere and encourage patient to share meals with family or friends. Next is to adjust diet before and immediately after treatment. Example here is the light or bland foods or the clear liquids. And next is to control environmental factors such as strong odors and noises, and avoid overly sweet, fatty, or spicy foods. Next is to encourage the use of relaxation techniques, visualization, moderate exercises before meals, and evaluate effectiveness of antiemetic drugs. The fourth is fatigue related to decreased metabolic energy production as evidenced by overwhelming lack of energy. Nursing management includes having the patient rate fatigue, schedule activities for periods when patient has most energy, involve patient or significant others in scheduling planning, establish realistic activity goals with patient, and assist with self-care needs when indicated such as ambulation, and increase activity level as the individual is able and encourage nutritional intake. And the last is knowledge deficient regarding illness, prognosis, treatment, and discharge needs related to unfamiliarity with information resources as evidenced by questions or requests for information. Nursing management include providing clear, accurate information in a factual but sensitive manner, answer questions specifically, and provide anticipatory guidance with patients or significant others regarding treatment protocol, length of therapy, expected results, possible side effects, and be honest with the patient. Ask patient for verbal feedback and correct misconception about individual's type of cancer and treatment. Provide written materials about cancer, treatment, and available support systems. Review specific medication regimen and use of OTC drugs. Address specific home care needs such as ability to live alone. Do pre-discharge home evaluation as indicated. And review with patient or significant others the importance of maintaining optimal nutritional status, increased fluid intake, and fiber in diet, as well as routine exercises. And stress importance of continuing medical follow-up. And we have here the references. So thank you so much for listening, and I hope you learned something from the video, and keep safe always.